Hello and welcome. Thank you for joining us here today for this YouTube premiere event on chronic idiopathic constipation. This program is brought to you through a collaboration with Medscape and the International Foundation for Gastrointestinal Disorders, or IFFGD. Together with me today is Dr. Darren Brenner from Northwestern University and patient advocate, Miss Erin Slater, a registered dietitian in Tampa, Florida. Today's program has been provided through a independent educational grant from Takeda Pharmaceuticals. Constipation is a very common symptom that is experienced in many people. Often, just simple lifestyle changes can help you to alleviate your constipation, but sometimes recurrent constipation or severe constipation might need a little bit more treatment. And so therefore, working with a healthcare provider is extremely important to ensure that you are able to relieve that symptom. So Dr. Brenner from Northwestern University, whose research and clinical interests include not only constipation, but irritable bowel syndrome, scleroderma, as well as constipation, opioid-induced constipation, and other lower GI disorders, is going to tell us a little bit more about constipation today and what that means when it is severe, refractory, or recurrent, or, as they say, idiopathic constipation. Miss Erin Slater, who is a registered dietitian at a hospital in Tampa, Florida, is here with us today really as a patient with chronic idiopathic constipation. A woman who has suffered from constipation since her youth. She's going to share a little bit about her story with us today and help us to understand better what she dealt with in getting her diagnosis and eventually treatment for her constipation. So first, before we begin, let's start with the basics. So Dr. Brenner, can you just briefly explain to us exactly what is chronic idiopathic constipation? And how might it affect the digestive system as far as like symptoms are concerned?
Yeah, so it's a great question, Cecile, and thanks for having me. The fact that it's defined as idiopathic is what makes it complicated. And I think that we spend a lot of time in the world of semantics trying to define all of these different subtypes. There are lots of individuals out there that suffer from occasional constipation, and this is something that is just very infrequent. Probably one of the most common ways that people present with that is when they travel. A lot of people come in and say, I went on a vacation, I went overseas, and I couldn't go to the bathroom at all. And that's something that we see on a regular basis, although interestingly, to this point, there is no consensus definition for occasional constipation. That's being worked on. Chronic idiopathic constipation is kind of a global overview of different subtypes of constipation. And so I like to get away from the semantics, especially when talking to colleagues and more so my patients, and really drill down to the different things we think about when somebody walks in the office and says, I'm constipated, because that can be very different from individual to individual. So if we look at these standard definitions, people will make chronic idiopathic constipation synonymous with functional constipation, synonymous with slow transit constipation. Probably to the average individual, none of these terms mean anything. Okay. So when I talk to my patients, I really try to talk about two different buckets or two different pathways that can lead to standard constipation symptoms. So the first one I like to call the transit pathway. We all eat. We can't get around that. And the food has to get digested and absorbed, and some of it becomes waste. So eventually that food's going to make it from your mouth down to the last storage area of the colon, which is the rectum. Okay. For many people, the problem is that propulsion or motility or movement is slowed. And so it takes too long, or the GI tract has difficulty pushing that food, subsequently stool, down the GI tract towards the bottom. And thus many of these individuals need a specific form of treatment. And I call these the bulldozers, which are the laxatives in any various shape or size, whether it is a bulking agent, fiber, osmotic, saline laxative, stimulant laxative, secretagogues. I'm going to run out of breath before we get to all the different classes that are available, but there's a lot out there. Okay. Once the stool gets down to the bottom into the rectum and there's enough stool in the rectum, you get a signal. There's a gut-brain interaction, and that signal says it's time to go to the bathroom. We've all had it. We all know what it is. It occurs on a regular basis, except for some people that have severe constipation. It can take a long time to get that. But once that signal's there, then there are a bunch of muscles in the pelvic floor that we control. They're skeletal muscles, and we coordinate them. And some people can't move those muscles. So I call part 2 the door. And the door is those muscles that have to be open to allow you to have a bowel movement. And so when we think about constipation, the thing that's interesting, I think, when I talk to a lot of patients is we always think about treating from above, but the door is the rate limiting step. Because if you can't open the door, everything backs up. My analogy has always been, if you get a hair plug in your drain and you turn on the water is going to back up into your sink. Until you pull the plug from the bottom, you're not going to clear it. So I really try to break this down into there's a transit issue and there's a door at the bottom. When we talk about constipation as a whole, I really do break it down into 4 major categories, and these can overlap each other. So I like to think when a person comes with constipation, if there's an obvious answer, it may not be the only problem. And this is important because when it comes to treatment, if you treat just one part of the problem, you're only going to get part of the answer and part of the benefit. So when we think about this, we really break it down into 4 technical categories. Secondary causes of constipation. These are simple. These are things we glean from somebody's history. Hypothyroidism does it. Diabetes does it. Medications, opioids, benzodiazepines. There's hundreds of medications that are associated with constipation. Mechanical obstructions, neuromyopathic disorders. You mentioned scleroderma earlier, Parkinson's, ALS, MS, and the list goes on. These are things that we know can cause constipation. And even if your patient has one or multiple of these, or if an individual suffering from these says, yeah, that's me, there are then other causes of constipation. Irritable bowel syndrome with constipation, slow transit constipation, which is synonymous with my argument for the bulldozer, and then what we call functional defecation disorders, which are issues down in that pelvic floor that are more subspecialized that block the person's ability to evacuate stool. So while we all think about constipation as I'm backed up, here's a laxative, I'll be cured type of process, it's actually much more complex than that.
Absolutely. Thank you for that explanation, though. I love the door and the bulldozer. That is so easy to understand, and definitely it's very educating to hear about all of those secondary causes, especially those other disorders, those very common chronic conditions like Parkinson's and others that could be causing your motility issues. Yeah. Definitely things to think about talking to your healthcare provider about at home. So, Miss Erin, so we got an idea about all the different types of constipation. I know that you have suffered with this for a very long time, and it would just love to hear your story about how you first had symptoms of constipation, and then, when you were able to finally get diagnosed and treatment.
Yeah, so thank you for having me today. I can tell you I wish Dr. Brenner was my doctor so many years ago. I would say I've always had some kind of idiopathic constipation, when I was younger. Maybe it was from eating a lot of macaroni and cheese and, just your typical kids diet. Maybe it was more than that, but it really all came together when I was about 17. And if you think back to when you were 17 or when your kids were 17, that's a very stressful moment in life. You're you're learning to drive, you're trying to do your college applications, you're maybe finishing up advanced placement testing, and it's a very stressful time, and definitely not a time in your life when you want to be dealing with constipation and abdominal pain and things like that. But that's actually what happened to me. I was about 17. And on the downside of that, when you're 17, a lot of doctors don't see you because you're still in the pediatrics. So I was my first, first I went to my primary care doctor, right? Because that's what you do. I had never really had any kind of chronic issues, ear infections, strep throat, that kind of thing. But, nothing that was chronic before. And so I went to my primary care doctor. I expected her to give me a pill, take it for 7 to 10 days and everything will be better. And I'll get back to my life and I'll finish my applications and I'll go back to, visiting college tours, things like that. But that's not what happened. And I actually ended up seeing my primary care doctor probably about 6 times. I'm sure she was sick of me. In the first 6 months when I wasn't feeling well. It was really affecting my daily life. I was having trouble eating. I was not wanting to eat because I was having a lot of abdominal pain. And I just wasn't getting the pill. I don't know. I just wasn't getting the answers that I wanted from my primary care doctor. And so being 17, I went to my first GI doctor, but it was a pediatric GI doctor who was probably more used to, constipation in 2-year-olds than abdominal pain in 17-year-olds. So, he did the basic exam, very, very nice guy, very thorough exam, and basically said, well, take some Pepsid, which was, definitely not my problem, or definitely not the solution to my problem. And so I ended up right before turning 18 in the ER. I remember it was Super Bowl Sunday. And the ER wasn't very busy, luckily, but I had just severe abdominal pain, that they just, basically said, well, follow up with your doctor. Okay. Went on to then see another GI doctor now that I was 18. And basically he looked at me, did a very thorough exam, very nice guy, sort of talked a little bit, but didn't have very good, maybe communication skills. Not like Dr. Brenner right there. It was an excellent explanation. Didn't get that kind of explanation. And, put me on some medication for the pain. Didn't really do much. But that was it. You have IBS with constipation, and, good luck, God bless. And so then I went to college. I was going to go to college. I was going to, keep going on with what my plans were, despite my daily pain, daily abdominal pain, daily, issues. I was losing more weight. Couldn't eat in the dining halls. Couldn't go to a Dunkin' run. Couldn't go on a Dunkin' run. Those kinds of college stuff. And ended up 3 years later seeing another GI doctor who, according to her website, was an expert in IBS, but she was not much of an expert in IBS, and again, really didn't get much help there. And I ended up seeing a fourth GI doctor before I finally got some answers and a better explanation as to what was going on, and some treatment to help. So it was a whole 5 years.
Wow.
Yes.
And in the end, they actually found that you didn't even have IBS at all, but it was completely separate abdominal pain and chronic idiopathic constipation.
Exactly.
Yes. And
exactly.
Totally can understand how that can be confusing. But I'm so glad that you were able to, after such a long haul, be able to get some relief. Darren, you see a lot of patients with constipation. Mm-hmm. It's one of the main things that you do, right? And research. So is this typical of what you see in your clinic?
Yeah, unfortunately, especially on the IBS-C spectrum, I've always said that part of my concern is that if a young woman walks in the door and has an abdominal symptom and a bowel symptom, instantaneously, it's going to be labeled as irritable bowel. Or there's the flip side of the pendulum, which is we're going to put you through 100 different tests. And if all of them are negative, we'll come back and say, it's negative, so we'll just assume it's irritable bowel syndrome. And because of this, if you look at the data that's out there, the average person, to your point, Erin, sees 3 to 4 practitioners, and it takes 3 to 4 years to make one of these diagnoses. And I think, again, going back to the semantics idea, we don't want to focus so much on how we define this as opposed to how best we can treat you. And what I mean by that is this. So you presented with abdominal pain. And that's the sine qua non, or the starter for irritable bowel syndrome. And there was a change in bowel habits. But we also know that people with constipation can have abdominal pain. And we also know, and I haven't had a chance to ask, but pain can be defined in many different ways. Is it sharp stabbing, dull, achy, cramping, or is it more of a bloating, distension, fullness, which many times differentiates away from the constipation? See people all the time where we get the bowel movements better, but those abdominal symptoms persist and we have to look in a different direction. So I knew where the process went. It sounds like you actually saw about 7 or 8 doctors before you got a definitive diagnosis of all of this. And I will apologize for the Pepsid issues. I don't know where that was going either. So
No.
But this is kind of what we hear on a regular basis in the day-to-day struggle for an individual who's going to go through this. It's many times try this over the counter, try that over the counter, try some water, try some fibrin. People are very compliant and they listen to what we do, but at some point we have to look for other things and think beyond that standard. This is all irritable bowel syndrome that we see very frequently.
Absolutely. So, Darren, you mentioned that sometimes doctors will take a patient and throw every test in the book at him. So Erin, did you have any tests?
Oh boy.
Oh,
With every doctor, you get at least a couple of tests. So I believe it with the pediatric that my primary didn't have any testing. She just said, you seem a bit stressed out. Nothing to do about that. The pediatric GI doctor, I believe, did like an upper GI, a barium swallow sort of study, and it felt to me, maybe at the time, that these tests were sort of random, and they were kind of just starting at the top and working down. So it was, I did a barium swallow. And that was completely normal. With the second GI doctor, I had an EGD, completely normal, no celiac, no, a little bit of gastritis. I mean, who wouldn't be stressed out by then? And then ER visits. So I probably had I had an ultrasound, which really just showed gas. I had a HIDA scan, I had a CT, all normal, all unremarkable, things that, and so, you're fine is basically the answer there. You're fine. Go on with your life.
wow.
Yeah.
That's a lot of tests.
Yeah.
Spanning the entire GI tract. So, Dr. Brenner, so what sort of tests would someone really, if you're really looking at diagnosing and really looking at chronic idiopathic constipation or someone who presents with constipation and trying to figure out what that final diagnosis is, what type of tests would be reasonable for a patient to expect?
Yeah, so I'm going to go back to the history, and I want to throw this out there because I think it's very important. And I don't know if this was part of your case, Erin. I'm certainly not going to ask you to divulge it in this venue. But one of the things that practitioners don't ask, so the first test that I think is very important, other than defining your symptoms, we have definitive symptoms for constipation: frequency, texture, straining, incomplete evacuation, obstruction, manual maneuvers. Went through those quickly. And then trying to differentiate whether or not there's a pain piece, which can overlap between chronic idiopathic constipation and irritable bowel syndrome with constipation. But what most people won't ask, and I beg every practitioner to do, so I'm going to look right at the camera, I know this is live, and say this: when you see individuals, whether they are young men or women, elderly, ask about histories of trauma or abuse, physical, sexual, emotional abuse. It portends an extremely high pretest probability of pelvic floor dysfunction. And I use that in a lead-in to discuss and answer your questions, Cecile. What are the tests? Because if you present with no alarm signs or symptoms at 17 years old, there aren't a lot of tests. We'll treat you with standard over-the-counter laxatives, maybe fiber, maybe water. Those are our first-line interventions. But when those fail, as I mentioned earlier, the door is the rate-limiting step. So the first test, if there are no alarm signs or symptoms, should be an anorectal manometry. And what this is, it's a little catheter that goes into the bottom about 8 or 10 centimeters. And we ask you to perform some provocative maneuvers that tell us if your muscles work or not. And if they don't work, it's physical therapy and biofeedback, because the muscles in the pelvic floor are skeletal, just like your arms and your legs. If you want to nod, you nod. If you want to wave, you wave. If you tear your rotator cuff, there's not an orthopedic surgeon in the world that's going to tell you to take a laxative and rub it on your shoulder for 6 months and see if you get your range of motion back. So again, I like to say with constipation, it all begins at the end, in the bottom. So the first test we recommend is anorectal manometry before we do anything else, including colonoscopies if there are no alarm signs or symptoms.
Fantastic. So Very educational. Thank you very much
Sure.
for that. So we're running out of time today in our program. And Erin, do you have any words of encouragement for people out there? I know you've had a long journey. So for those people at home that are with us today, do you have anything to say?
Yeah. So I would say, and to your point, no one ever asked about constipation. I said I had abdominal pain, and they never asked about constipation, never asked about any over-the-counter medications that I could have taken or would have taken. I would say, as a overall advice for some others that might have similar symptoms, is that if you are talking with your doctor and you're communicating and you're feeling like they're not listening, or you're not getting the feedback, you're not sort of connecting with that, don't wait to find somebody who does connect with you, and does listen and does ask those kinds of questions. So
Awesome. Thank you very
Yes.
much. Thank you. And so before we wrap things up, Dr. Brenner, what are some resources that the people at home can have for chronic idiopathic constipation, where they can learn more and maybe for themselves or someone they know that's suffering, that just to learn more about the illness as a whole?
Yeah, sure. I think there's a lot of places you can go on the web, and I'm not a big fan of that. I would recommend, the academic websites. I'll do a shameless plug for Northwestern, Mayo Clinic, Michigan, Cleveland Clinic have some great resources. The IFFGD. I mean, your institution puts out all kinds of patient-centric handouts that really cover the gamut of these types of disorders, not just the treatments that are out there, but the underlying causes and how we differentiate these disorders and the diagnostic studies and the studies that should be done. So I always say, find a credible resource, and probably your best credible resource is going to be your practitioner. Ask your practitioner for that advice. Where can I go? Where can I read? Where can I learn? What's going to best suit me? Because again, there's some very, very good literature out there, but there's some very, very confusing data out there as well that can really send you down a rabbit hole that we don't want anybody to jump down. So
Absolutely. Well, thank you so much for the shameless plug for IFFGD. Really appreciate that. You just mentioned asking questions of your doctor. So when people are coming in and they have symptoms that are similar to what we've talked about today, the constipation, maybe some pain, what are some things that they should be asking their doctor in that visit?
I mean, I think that initially, especially for a first visit, the goal is to really kind of tease out the entire symptom profile. And so, most practitioners will use a review of systems, especially if you're a subspecialist like me. We will run that head to tail analysis and try and figure out what's there and what we're dealing with. I like to ask from an individual's perspective what they think is going on, because that's important. They may be misinformed, they may be right on. We want to make sure that we have that understanding up front as to what we think is the problem, because that will help us define goals. I mean, I think one thing that we as practitioners do poorly a lot of times, because we're just under time constraints, is to ask, what are you looking for? I mean, we're so trained, illness plus treatment equals better, but sometimes it's more about the quality of life. And, even listening to your story, Erin, going through those years and years in practitioners, I'm sure you left a lot of offices saying, yeah, that didn't do anything for me, or I'm no better than I was when I started. And about 40% of people with these types of disorders give up, because they see multiple practitioners, they don't get anywhere, and they're like, this is my lot in life, I'm done. I guess I just have to deal with that. So I always say in the first visit, tease out what the symptoms are, start to define your differential diagnosis, ask your practitioner what they think is going on, and then set parameters for what are the long-term goals and short-term goals realistically, and then how is this impacting your quality of life? Because especially with constipation, I say this a lot. People ask us all the time, how do you know when you fix somebody's constipation? And I say that's easy, and it has nothing to do with criteria. Okay, the criteria are relevant. There are two ways I know that I have done a good job. When you walk in the door and say, I'm comfortable and I'm living my life, you may still meet some of our criteria for constipation, but you are in a good place and you are where you want to be. On the opposite side, the person that's completely unrealistic. you fix pretty much everything, but every now and then there's a little blip on the radar, and there's no way to do that. But it really is a patient-centric, patient-driven quality of life disorder, and we have to look into that a lot more than I think we do on a regular basis.
Absolutely. And so Erin, what sort of things do you wish you had asked your provider or informed? So you said no one asked about your constipation. Did you tell them about your constipation?
You know what? That's a great question. Because I'd always been constipated. I mean, it was normal for me. I've never lived in anybody else's body, so I was always been in my body, and so it was normal to go 3 or 4 days without a bowel movement. I mean, that would be defined as constipation, but that was completely normal for me. And the symptom that really was most bothersome to me was the abdominal pain. And so was that connected? I mean, obviously it was connected to the constipation, but I never saw that. I never saw the constipation as the issue. I just wanted to feel better. I didn't want to be in pain anymore. I wanted to be able to eat without having to lay down for 2 or 3 hours. Afterwards in pain, I wanted to, live a normal life. I wanted to go to college and live a normal life. So, and so that's, I think what I wish I would have said or would have done is to prepare more before the doctor's visit. You think about, you make an appointment and it might be a couple of weeks or a month in advance. And I think during that time, it's good to think about what you want to say. Write down the questions or write down the bullet points about, this is the problem for me, and not just go into the appointment blank and expect the doctor to do all the work, right? It's a partnership, right? It's my body. And I might see him for 10 or 15 minutes or whatever. But you can't expect the doctor to just kind of snap their fingers and you get all better. So I think that preparation before the visit, thinking about what you want to say, what you want to question, would have been helpful to me. Yeah.
Right.
And the realistic expectation of no magic bullet.
Right.
Still.
No magic bullet.
Right.
Yes.
Right.
But you are so right. I can tell you that when people bring their history, they write down their historical perspective, what has been done, what their expectations are. It's a launching point where I can sit in my office and review this in about 2 minutes. We can spend the entire time talking about what's most important to you. So I think that is such a poignant message to pursue. Anything
to add to her preparation? Any other things that would be helpful for you when people walk in, besides having this written down, the history, and what other things would be helpful?
The history is important. The previous medications that have been used, different dietary modifications, if anything's been done holistically, what diagnostic studies have been done. But again, most importantly, what is your goal? That's what I think we miss the most. We try to treat the illness. We try to cure the illness. Like to your point, Cecilia, you just said some of these are incurable. There's no magic bullet. Right. So what is the goal? And can we set expectations together to get you to that best life, that Dunkin' run that certainly having gone to college, I can wholeheartedly relate to and wanted to do as well.
Absolutely. So working with your healthcare provider to ensure that you are really getting to the root of the cause, and whether it's a bulldozer or a door, and then understanding all of your symptom profile, understanding what is important to you in your treatment process, understanding, of course, that this chronic idiopathic constipation has the word chronic in it, which means it's chronic. It is something that you will be living with for the rest of your life. Working with a healthcare provider and being open and honest about all of your symptoms, about all of your goals, is really going to ensure that you get the best treatment plan possible for you. Thank you so much for joining us today. We're out of time. Many thanks to, again, the Independent Educational Grant from Takeda for this great program on chronic idiopathic constipation, a collaborative effort between Medscape and the International Foundation for Gastrointestinal Disorders.